Good morning and welcome to the Chamber's annual Safety, Health, and Wellness Symposium. Thank you for joining us and for your ongoing participation and interest of the many educational events we offer our members. My name is Lori Mertens, and I've been involved with this committee for the past 5 years. The Chamber of Manitowoc County Safety, Health, and Wellness Council provides the community with education and resources to promote wellness practices that enhance health and safety in the workplace. One of our signature events in the Manitowoc County National is our National Health and Fitness Day. Our event, You're It, Get Fit, is a way to challenge employers to offer fun ways to promote a healthy lifestyle by encouraging employees to engage in physical activities. The challenge requires participants to engage in 30 minutes of physical activity during the day, and for organizations to track the amount of employees who participate. Each year we have more companies participating in a great variety of free physical fitness activities available for those who enjoy the challenge. After the event, the employers submit their evaluation form and a winner is selected. It gives me great pleasure to share that we awarded Cason Corporation as the winner of the 2021 You're It, Get Fit Challenge. Congratulations again to Cason Corporation. Now we'd like to move forward with our first speaker. If you have a question during or after the presentation, please ask it through live chat. I will read the questions to our guest speakers at the end of their presentation. Our first speaker is Rachel Reese from Aurora Baycare Medical Center. Rachel is a registered nurse and currently holds the role of neuroscience market manager for the Baycare Clinic. Rachel has a strong background working with stroke patients in the acute phase, from emergency room to the procedural area. Her primary roles involve public outreach, educating the community and EMS providers on symptom recognition and the impact of stroke in northeastern Wisconsin.
Good morning. Thanks everybody, and thank you to the Chamber for having me this morning. I'm excited to be here to talk about stroke to this audience because I think it's something that maybe in the workforce or among our employees we don't think that is something we need to educate on. So I'm hoping you can take something away from the presentation this morning and bring that back to your employees. Some objectives we'll cover today: facts, we'll define what stroke is, risk factors, treatment, and then some key takeaways at the end. First, I want to start with what the impact of stroke is. So stroke, many people may not be aware, is the 6th leading cause of death in the US. Previously, before COVID, it was number 5, but COVID pushed us back to number 6. On average, about every 40 seconds, someone will suffer a stroke. There's about 800,000 strokes per year in the US, and it is the major leading cause of disability. There's almost 4.7 million stroke survivors in the US, and by 2030, about 4% of the US population over the age of 18 will have had a stroke. That is a projection. Now let's talk about cost. Not only the personal toll on patients and families, there's a tremendous financial burden to the economy due to stroke. So according to the American Heart Association and American Stroke Association, between 2012 and 2030, the direct medical cost of stroke is projected to increase from $72 billion to about $184 billion. Some of that has to do with our aging population. As we do age, after the age of 55, the risk of stroke does double for every successive decade. And the indirect cost, and that's due to premature loss of labor and then premature morbidity, that cost is projected to go from about $33 billion to $56 billion. So there is a huge financial burden to the economy due to stroke. And this just puts some numbers on, this graph you're seeing puts some numbers on by age. So the blue line, the light blue line at the top, that's a total direct and indirect cost of stroke in the US by billions. So again, just as I said in the last slide, that's going to rise to about $184 billion by 2030. And then you can see by age. So the light green, that's ages 65 to 79. and that is going to see the most indirect and direct cost from stroke because that aging population again. But I do want to point out here the red line, so ages 45 to 45 to 64, that is on a continuous incline there. So we are seeing strokes among younger and younger ages, and you can see that here in that graphic. Let's talk about death. I don't want to get morbid here this morning. It's only 8 o'clock, but I just want to show you in the state of Wisconsin, stroke-related deaths per 100,000 people. And the CDC, this map only includes ages 35 and over. So between 2017 and 2019, you can see here in Northeast Wisconsin, there was about 645 deaths per 100,000 people in that area. Here more to the south, it's about same 645. The interesting thing about this map, when you think about where our hospitals are and where our designated stroke centers are in the state, these lighter areas, their stroke-related death is less, which makes sense because there's better access to care for patients. If you look here up in the UP, these dark purple areas, their death rate is much higher because of stroke, because it takes that much longer to get to a center that can provide the care that they need. There's a real lack in stroke care in our northern, especially northwestern part of Wisconsin. So there is some state initiatives to try to improve that. So this map is something to watch as we move into the next decade. Stroke affects all ages. As I said in the first slide, it does increase with age, but they can and do occur at any age. And I will say COVID has changed the stroke population in the last 24 months. Those with a positive COVID infection do have a higher risk of suffering an ischemic stroke, and that's due to some of the increased coagulopathies that happen with stroke. In 2009, 34% of people hospitalized with stroke were less than 65 years old. So here's some familiar faces, some celebrities that you might recognize that actually have suffered a stroke. Bret Michaels, Malcolm from Malcolm in the Middle. Any of my Games of Thrones fans out there, you might recognize this face. And then this last one, I'm going to give a little shout out to. This is Drake White. He suffered a hemorrhagic stroke about 2 years ago. He's one of my favorite country singers, and he's coming to Green Bay in October if anybody's interested and you feel safe to go out and venture to a concert. But he had a hemorrhagic stroke and he's back on stage and performing. He does have some disabilities on his left side, but it's nice to see him back out and doing his thing. So I've told you the impact of stroke, what it's going to cost you. Now, what is it? Most people maybe have a very high level understanding of what a stroke is, but here I'll give you a little bit more in depth. So it's a continuous supply of oxygen to the brain is essential to maintain function. So our brain needs blood flow and oxygen to function all the time. Without it, you're going to have tissue damage. And a stroke occurs when a blood vessel in the brain is either blocked, so that's an ischemic, or burst, so that's a hemorrhagic, so there's bleeding in the brain, and that's causing blood flow to stop to the brain. Ischemic stroke, those blockages account for about 87% of all strokes, and hemorrhagic strokes account for about 13%. Both are medical emergencies, but treatment is very dependent on the type of stroke that the patient is having. So here, just a quick graphic on ischemic stroke. So you can see here, these are the blood vessels going up to the brain, and then here there's a blockage. So the side of this patient's brain is not getting flow. So you can see this darker area is all tissue that is being damaged. And then here is a hemorrhagic or bleeding stroke. So a rupture in either one of these small blood vessels or from a brain aneurysm, whatever the reason may be. But the brain can't handle increased pressure in the brain. So if there's bleeding in the brain, that causes pressure and then therefore lost blood flow to the brain. Well, what's a TIA? These are those mini strokes. Many people will say, well, I had a mini stroke or my mother suffered a mini stroke. But what is that? So a mini stroke is actually really nothing mini. So when you think of something mini, you think of something cute, right? Like a Mini Cooper, a Minnie Mouse, or a Mini Driver. But really a mini stroke is not cute at all. This is your body's way of telling you that something else is going on. Something bigger is coming. So these symptoms should not be ignored. So a TIA or mini stroke occurs, it's when blood flow to the brain is disrupted, but the body is able to open that blood flow on its own. So they usually last anywhere from 5 to 15 minutes, but it should not be ignored. There's about 200,000 to 500,000 of these per year. And if a person does suffer a mini stroke, the risk of a future stroke within the next 90 days is about 9 to 20%. One good way I like to talk about TIAs is people say, well, if blood flow is disrupted, isn't tissue dying? And the answer to that is yes, but if blood flow can be restored quickly, that tissue can regenerate. So it's very similar to if your hand falls asleep. It starts getting numb and tingly, but as soon as you either reposition your arm or get blood flow back to that hand, it starts to wake up again. So it's very similar with a TIA or a mini stroke. There's a temporary disruption in blood flow or oxygen supply, but then once that's restored, the brain essentially wakes up again. Okay, so risk factors. We talked about the kinds of strokes. We've talked about TIAs. Well, what are the risk factors? Who's going to suffer a stroke? And the same risk factors as for cardiac disease really go hand in hand with stroke, because stroke is not a brain disease. Stroke is a cardiovascular disease. It's a problem with blood flow and the vessels in the brain. So risk factors would be smoking, high blood pressure, high cholesterol. If you have known carotid artery disease, you are at risk for stroke. Atrial fibrillation, which is quivering of the upper chambers of the heart, excessive alcohol intake, all of those things can increase your risk factors for stroke. These are some old ads, very old. I don't know if anybody remembers any of these, but clearly our tune has changed when it comes to smoking. We don't see ads like this anymore. Risk factors continued. As I said, after the age of 55, the stroke risk does double for every decade a person is alive. Gender, I hate to say it, ladies, but we are more likely than men to suffer a stroke for reasons being of women tend to live longer, and there is some research out there to say some of the hormone changes do increase risk of stroke. Ethnicity, so African Americans, Hispanic, Asian, Pacific Islanders, they are more likely to suffer a stroke than Caucasians. Family history, history of a previous stroke, so TIA, those are all other risk factors that would increase chance of stroke. And some of these, like I mentioned on the slide prior, smoking, diabetes, high blood pressure, high cholesterol, those are things we can modify. Those are things we can control. These on this slide, these clearly are things we can't control, our age or our gender. These are things we just have to be aware of. So symptoms. Let's say maybe in the last 8 years, the acronym for stroke, which used to be FAST, the American Heart, American Stroke Association does still recognize FAST, but here in the state of Wisconsin and many other states in the US have actually adopted BFAST. So the B and the E actually includes balance and eyes, and the reason for that being we catch more strokes that occur in the back part of the brain in our posterior circulation. So B stands for balance, loss of balance. Eyes is vision issues, any blurry vision or loss of vision on one side. Face, so facial droop on one side. Arms drooping to one side or the other, and the same can be said for legs. So arm or leg weakness, we could really expand that too. And then as well as speech. So difficulty speaking or unable to speak. Speech is one of those symptoms that sometimes gets a little confusing because it can be slurred speech. It can be difficulty finding words. It can be the person is talking in complete, clear sentences, but you ask them, when's your birthday? And they start talking about something completely off the wall. And it's because their brain just isn't processing what we call Wernicke's aphasia. So speech can be multiple things. We'll see patients that come in through the ER and whoever is with them says, well, she's just really confused. Well, we would automatically call that as a stroke alert, and most ERs would, because we need to rule that in before we would rule that out as just confused or altered mental status. And then T is terrible headache or time. Terrible headache and time. So terrible headache would be a symptom of a hemorrhagic stroke. Patients who come in with a hemorrhagic stroke, if they're able to talk with us, they say, I have the worst headache of my life. And it's a sudden onset. It's not like a migraine where they start with maybe some visual disturbance. Typically, a hemorrhagic stroke is a quick, all of a sudden, boom, you get hit like a thunderbolt to the head and you have this terrible headache. And then time is important because we want people to call 911, and all of our treatments depend on the time the patient arrives to the hospital from when symptoms started. And I'll get into that in the next slides. So time is brain. Time is not on your side during a stroke. Similar with a heart attack. Time is muscle, time is brain. For every minute during a stroke, 2 million brain cells will die, and a delay in treatment will greatly affect the patient's outcome. So will that patient go home with their family, or will they end up in a long-term care facility? So what are the treatments? So treatment depends on the type of stroke the patient's having. So if it's an ischemic stroke, we have IV medication that we can give the patient. If it's a hemorrhagic stroke, then we have a different treatment plan. But upon arrival to the emergency room, what will happen is, in the perfect world, the patient arrives via EMS. They've called 911. They arrive via EMS. We have our CT scanner ready. Patient is brought right to the CT scanner because we need to know, is there blood in the brain, or is this possibly an ischemic stroke? So once we get that first picture with a CT scan, then we know, okay, here's what we're dealing with. Here's what our treatment plan is going to be. So time of symptom onset is very important, and I'll get into that in the next slide. But if you're ever with somebody, or if you're at work and one of your coworkers starts showing these symptoms, please take note of what time it is, because any emergency room is going to ask you, do you know what time these symptoms started? That will greatly help the medical team into figuring out what treatment plan we can offer. So why is time so important? Well, time is important because if it's an ischemic stroke, we do have the option to give what's called alteplase, or TPA. TPA came about in about 1996. And it's an IV thrombolytic medication. So what we do is we give that through an IV in the arm, and it's able to break up blood clots, and it'll break up a blood clot in the brain or anywhere else in the body. But this can only be given up to 4.5 hours from symptom onset. So if symptoms started at 7 a.m. and the patient arrives to the ER by 10, they're still within that safe time window. If symptoms started at 7 a.m. and they don't show up to us until about 2 p.m., then they're outside of that window. We no longer have that option. There are some contraindications to TPA which are listed there for you, and the medical team would ask that of the patient if they're able to answer, or a family member if they have any of those conditions. And the reason being, we wouldn't want to cause any further serious bleeding that would outweigh the benefit of the TPA. And then there also is mechanical thrombectomy. So this is a procedure that we can do for patients that come in with an ischemic stroke, not for a hemorrhagic stroke. This is my Disney World. This is where I worked before I took this job, for about the last 7-8 years. And I started my career with IR when we were first doing some of these studies to really advance mechanical thrombectomy. So what is it? This is a procedure that we can go in and actually remove a clot from a blood vessel in the brain. Very similar to when someone's having a heart attack. They can go in through a vessel in the groin, get up to the heart muscle, and either open up that vessel or take out a blood clot. We can now do the same thing in the brain. So a catheter is placed in an artery in the groin and advanced all the way up to the brain. We actually sit them right kind of at the base of the neck, honestly. And then the clot is removed either using a stent retrieval device or a suction device. This is done by specially trained physicians at designated stroke centers. So when I showed you that map of Wisconsin previously, we have 6 stroke centers in our state that currently have a designation to do this. We're very fortunate in Green Bay. We have 2 centers that are licensed to do this. So when you think about, Green Bay has 2 centers, and then we have 3 centers down in the Milwaukee area, and then Madison. We're pretty fortunate here in the Green Bay, Northeast Wisconsin area to be able to offer it. Mechanical thrombectomy can be done up to 24 hours from symptom onset with proper imaging. So what we have to do, again, we do that CT scan, and then we would do what's called a perfusion scan to see if there's still tissue that's salvageable, and if there is, then the patient could be taken for thrombectomy. So here's some pictures of what the procedure room looks like, a graphic of how we get up into the vessels of the head and neck, and then here is a vessel that's closed, you can see circled in red, and then post-procedure it's open, there's now blood flow going to the side, that side of the brain, and then a picture there of a stent retriever with a piece of clot on it. So So again, this is my happy place here. It's just like plumbing, right? We're just going in there and roto-rooting and sucking out any blockage that might happen. So what can you do as employers? What does this mean for you? You're probably thinking, well, I don't know how this pertains to me in my workplace. But really what we would ask of you as employers when we think about the cost and how this could impact the economy and the burden of lost labor, really what you should be doing as employers is incorporating stroke education into all of your wellness programs, health risk assessments. Just like I said, cardiovascular disease, we focus a lot on cardiac disease, but sometimes stroke isn't thought of as something for our working population, but we are seeing it in younger and younger ages. So I really feel strongly that we could work this into these programs. So here's some of the options that Aurora does offer, and I know many employers, whoever you work with for an occupational health program, probably all have these same things. So health risk assessments, blood pressure screenings. We'll do blood pressure screenings in the community, and it's a great place to talk to patients not only about their blood pressure, but what the risk factors are of having high blood pressure. So you can read some of those there. And then there's online resources as well. There's stroke risk scorecards that people can go in and give themselves a score of either low, medium, or high of where they fall on the stroke risk spectrum. And then even working in stroke to some of the national health observances. So February is Heart Month. You can work stroke into that. Go Red Day is the first Friday in February 2022. It'll be on February 4th. May is Stroke Awareness Month, so that's a great time to bring in stroke education. You can read all of those there. World Stroke Day is coming up on October 29th, and Great American Smokeout in November. So all ways that you could incorporate that into your workplace. So some key takeaways from this presentation today is, again, encourage staff to know what their risk factors are, educate on signs and symptoms, integrate stroke into your workplace, diet, exercise, all of those things, and then encourage your employees to talk to their primary care provider, or even if there's an on-site nurse that they could talk about what stroke risk factors are. And again, stroke is common, it's disabling, it's costly, but really it is treatable when we're able to get patients to where they need to be in a timely fashion. Time is the most important factor when treating stroke. And I will leave you then one more time with that Be Fast acronym. You can post this in your workplace, or hold a challenge within your workplace of, hey, what does the B stand for in Be Fast, and maybe offer some kind of employee incentive that way. So yeah, there's that for you. And that is what I have. So thank you so much. I have my information there if there's questions or comments. And then also Chris Pankratz is our Advocate Aurora Wellness Services and Employer Clinics Coordinator. Her information is there if you have questions for her on how you can incorporate this into your workplace. So with that, Lori, I'll kick it back to you.
Great. Thank you, Rachel. Any questions that we have? Then we will move on with a short video from the Manitowoc County Health Department.
Hello, my name is Stephanie Lambert. I'm the Health Officer of Manitowoc County and have been asked to give you an update on the local COVID-19 pandemic and response. Before I begin, I wanted to quickly introduce myself as I'm relatively new to the position. I was born and raised in Manitowoc County, left Manitowoc to study at St. Norbert College, and I left Wisconsin following graduation to join the United States Peace Corps. There I was deployed to Swaziland, Africa, where I spent 2 years as a community health educator. This is where I found my passion for public health. Upon completion of service, I returned to the U.S. to train for my master's in public health at Emory University. I then began working for the Centers of Disease Control in Atlanta, Georgia, where I held positions in disease surveillance, program management and evaluation, and health communication. Surprising myself, I returned to Manitowoc in November 2020 during the peak of the pandemic to assume the role of health officer. It has been a challenge, but a rewarding one, and I'm grateful for the opportunity to serve my hometown. So, back to COVID. A lot has happened in the last 21 months. Do y'all remember this news alert? January 2020. It may not have made cable news, but this is when the scientific community was first put on alert. Novel viruses that can spread person to person are never good. And it wasn't good. This novel virus, now identified as a coronavirus, was really good at spreading from one person to another. Within 2 short months, the virus had been detected in 165 countries. COVID-19 was officially a pandemic. It didn't take long for Manitowoc County to become affected. On April 3, 2020, Manitowoc confirmed its first case of COVID-19. Case counts remained relatively low most of last spring and summer, but increased dramatically in the fall. We saw exponential growth, with case counts doubling on a near weekly basis. Cases peaked in mid-November with 132 cases reported in a single day. During this time, the health department worked harder than it ever had, with staff working 12-hour days, 7 days a week. Beyond disease investigation and contact tracing, we were a community resource for COVID education, prevention, and eventually, finally, a resource for vaccination. On December 14, 2020, just under 1 year from that report out of Wuhan, FDA authorized Pfizer as the first COVID-19 vaccine for emergency use. Authorization for the Moderna vaccine came shortly thereafter. The health department received its first shipment of vaccine the week of January 4th, and within 24 hours had shots in arms. The Manitowoc County Health Department vaccination clinics were wildly successful. We were able to administer more vaccines in a single day than anyone else in the county, and administered over 14,000 doses of vaccine at our mass vaccination sites. We were able to provide in-person interpretation services for Spanish and Hmong speakers, provided drive-up injections for people with disabilities, and partnered with the Aging and Disability Resource Center to provide transportation to those in need. One time, some guy came wandering in saying he heard something about free shots. We got him vaccinated too. Following the explosion of cases last fall, the county saw a relatively steady decline in cases from November through July. In spring, CDC announced that vaccinated individuals could remove their masks and return to pre-pandemic activities. It truly seemed like the worst was behind us. Unfortunately, a mutation of the virus, B.1.6172, otherwise known as Delta, had a different idea. The Delta variant has shown itself to be considerably more infectious than the original strain of SARS-CoV-2. This adaptation quickly led the Delta variant to become the predominant strain in Wisconsin, where it now represents almost 100% of infections in the state. Unfortunately, the Delta variant has brought a new chapter to the fight against COVID-19. Manitowoc County has seen a surge in cases of COVID-19 over the last several weeks. After seeing only a handful of cases per week over the summer, we are now recording dozens of cases a day. The average age of infection has dropped slightly, from 45 in January to 38 in September. We expect the school year to accelerate this trend unless public health guidance, such as universal masking and quarantines, are followed. With cases rising, so unfortunately are hospitalizations. The Northeast region has seen a spike in hospitalizations for COVID-19 in the last month, and our hospitals are now seeing numbers not seen since last January. Hospitalized patients are growing younger. The average age of hospitalization for residents in Manitowoc County has decreased from 66 in January to the age of 53 in August. This may be due to the age distribution of vaccinations in Manitowoc County, where more than 85% of residents 65 and older have gotten vaccinated. Vaccination for COVID-19 continues to be our strongest tool for bringing an end to the pandemic. Right now, only 53% of residents have received at least one dose of vaccine, and less than half of residents under the age of 45 are fully vaccinated, allowing the virus to continue circulating within our community. While breakthrough cases are possible and do occur, the vaccines are still remarkably effective in protecting against severe disease and death. In other words, once you are fully vaccinated, you are less likely to become infected. And if you do become infected, you are less likely to become hospitalized or die. Vaccines are the safest way to end the pandemic. As long as a significant number of immunologically naive people exist, this virus will continue to circulate. This means that the pandemic will not end until most people reach some level of immunity, either through infection or vaccination. This has been the most studied vaccine rollout in human history, and we continue to see the protective effects of vaccination. The data set shown is from a recent study involving more than 2.4 million vaccinated persons and 240,000 infected persons. As you can see, the risk of major adverse events like pulmonary embolisms, arrhythmia, and acute kidney injury increased significantly with infection, whereas vaccination provided protection from these and other health complications. Again, this virus is very contagious. If you're not vaccinated, there is a very good chance you will become infected. Data continue to show that vaccination is much safer than COVID-19 infection. So what can you do? If you're not yet vaccinated, get your vaccine as soon as possible. Manitowoc County currently has a very high burden of COVID-19 disease, and it is recommended that you wear a mask in all indoor public settings, regardless of vaccination status. Stay home if you are sick, and seek testing if you have symptoms of COVID-19. If you are a close contact of someone diagnosed with COVID-19, the guidelines differ depending on whether or not you are vaccinated. If you are vaccinated, you don't have to quarantine. Wear a mask when around others and monitor for symptoms for 14 days and get tested 3 to 5 days following exposure. However, if you're not vaccinated, you are much more likely to become infectious yourself. So we ask that you stay home and away from others for 7 to 14 days. Monitor for symptoms for the full 14 days and get tested if you become symptomatic. Now, if you test positive for COVID-19, we ask that you isolate immediately to avoid infecting anyone else. It's recommended that you notify close contacts or anyone that you've been within 6 feet of for a combined total of 15 minutes or more over a 24-hour period. What can you do as an employer? Well, prioritize COVID-19 vaccinations among staff. Local employers have done this via mandates, incentives, or even penalties for unvaccinated workers. Require universal mask wearing. This limits spread by stopping viral transmission at its source. COVID-19 is different from many of our other illnesses in that a person becomes contagious before they start experiencing symptoms. Promote physical distancing at all times. This may mean splitting up breaks and lunch hours to avoid crowding in small areas. This is especially important in times when masks cannot be worn, such as when people are eating or drinking. Create an environment where employees can stay home when they are sick. Improve ventilation, such as opening windows and doors whenever possible. And sanitize high-touch surfaces as often as possible. And of course, we should all be diligent about washing our hands. So what's next for the pandemic? Well, we anticipate federal guidance about booster shots to come out later this week. At this time, it's not yet known if and when booster shots will be recommended, if they will be for all people, or if they'll be for just certain high-risk populations. Stay tuned. Currently, children under the age of 12 are unable to become vaccinated. However, that is likely to change in the coming months, with FDA currently reviewing data for 5 to 11-year-olds. Finally, the White House has announced plans to increase the number of vaccinated Americans. This includes requiring all employers with 100 or more employees to ensure workers are vaccinated or tested weekly for COVID-19. And it requires vaccination for all federal workers and contractors, as well as healthcare workers in systems that accept Medicare and Medicaid. The plan also requires employers to provide paid time off to get vaccinated. Please note that these rules are still under development and have not yet taken effect. I want to leave you with a final note of comfort. This pandemic will not last forever. I know that this last year and a half have been a really challenging time for all of us, but eventually the pandemic will run its course and things will be okay. In the meantime, let's all do our best to be kind to each other and to stay as well as possible. Thank you.
Thank you.
Our next speakers are Karen Allard and Paula Allen from Bellin Health. Karen is a registered nurse with experience in obstetrics, nursery, emergency, and GI units. She also has a background in quality with a focus on improvement for public reputation and reimbursement programs. She has a master's degree in patient safety leadership. On a personal side, Karen enjoys kayaking, traveling, reading, and volunteering. Paula is a Bachelor of Science prepared RN with experience in pediatrics, pediatric hematology, oncology, and adult medical surgical units. She also has held additional roles, including patient safety, quality, regulatory, and infection prevention. She has a master's in organizational leadership and is certified professional in patient safety. On a personal side, Paula enjoys reading, golf, exercise, baking, and travel. Together, Karen and Paula have over 40 years of healthcare experience and currently serve in the role of patient safety specialists at Bellin Health System.
Good morning, and thank you for inviting us here this morning. I am Paula Allen, and this is Karen, and we are here to talk to you about psychological safety being an important component in your workplace.
And we just wanted to start this morning with the story of three different organizations. At Company A, there is a new colleague who notices what he believes are OSHA-required safety features are not present in the new plant. He's not quite sure though, so being new, he doesn't want to cause any problems, and he stays silent. At Company B, a very seasoned colleague sees that there's a problem with the boxes used to package their product. The manager, however, has an attitude with a no excuses policy and publicly calls out staff who don't meet target production quotas. So the seasoned colleague doesn't speak up. At the third company, however, the manager asks staff for input. She tells them, "You are my eyes and ears. I don't know everything, and I need your feedback to help improve our processes." Those are three examples of psychological safety or not psychological safety.
Psychological safety has been referred to as the single most important characteristic for successful teams and leads to decrease in turnover and increase in effectiveness. Psychological safety is the belief that your environment is safe for interpersonal risk-taking, meaning that asking questions, pointing out problems, and suggesting innovation will be responded to in a respectful manner.
So what are our objectives for today? Today we want to cover what psychological safety is, why it's important, talk about some of the challenges to creating psychological safety, how to assess for its presence in your workplace, and also tips on how to grow this. Why do we want to talk about it today? Psychological safety has been referred to as the single most important characteristic for successful teams and leads to decrease in turnover and increases in effectiveness. So what is the definition of psychological safety? The definition of psychological safety is a belief that it's safe to take interpersonal risks, that a person will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. Anyone should be able to ask a question without looking stupid. Anyone should be able to ask for feedback without appearing incompetent. Anyone should be able to be respectfully critical without appearing negative. And again, anyone can suggest innovative ideas without being perceived as disruptive.
We see teachings of psychological safety going back to the 1960s. Edgar Schein and William Bennis wrote, "A person's anxiety about being basically accepted and worthwhile." Edward Deming taught us to drive out fear so that everyone may work effectively for the company. There is a book called The Fearless Organization by Amy Edmondson that we use as our foundation at Bellin. And she taught us, or she discovered that teams with better outcomes were admitting more mistakes, while teams with fewer outcomes were less likely to hide their mistakes. More likely to hide their mistakes. So psychological safety is really a growing body of knowledge on psychological safety in the workplace. It's flourished in the recent years, and organizations devote more resources and time to deepen their understanding of the factor in driving effectiveness. Psychological safety is important because it's one of the key factors contributing to better performance of organizations. It stimulates work engagement, promotes a knowledge-sharing environment, and positively impacts job satisfaction.
So let's talk a little bit more about the importance of psychological safety. In 2017, Gallup did a poll that revealed that only 3 out of 10 workers in the US felt that their opinions really seemed to matter at all. And Gallup, being the organization that it is, was able to do some other research which showed that if you could increase that ratio up to 6 out of 10 employees, organizations would have a 27% reduction in turnover, a 40% reduction in safety incidents, and a 12% increase in productivity. Lots and lots of papers are out there showing the link between increases in psychological safety and greater returns on asset, innovation for research and development teams, increases in manufacturing process innovation, higher goal achievement, and increases in successful implementation of new technology. I thought it was really interesting to learn that Google, with all of its analytic capabilities at its fingers, did their own study of their teams and looked at their successful teams. The single most important predictor of successful teams at Google was whether or not they had high psychological safety. So we're from Bellin. Why is psychological safety important in healthcare? We wanted to talk a little bit about that so that you could understand why psychological safety is so important to us and what we do. First of all, psychological safety supports learning. It's the ability to listen, to ask for help, to understand what's happening around you. It affects the team, the department, and the organization as a whole. And also, care teams may be less likely to take risks involved with implementing new technology, new processes and things without some assurance that their missteps and problems with the implementation won't be held against them. So that's part of that learning in healthcare organizations. That's a constant experience for us in what we do. It also impacts risk management in the healthcare organization. There's higher incident reporting rates when there is greater psychological safety. Individuals are able to speak up in different work environments to bring up process failures, hopefully before they actually happen, so that you can try to prevent incidents from happening, which positively affects your risk management. There's greater innovation, allowing individuals and teams to share more ideas, to support rapid cycle learning and development. And also, job satisfaction and job meaning are a big thing for us. Makes people feel more valued, respected, committed to their jobs over time. And I think all of those things that I've said apply to anybody in a Chamber of Commerce kind of situation or manufacturing situation. One thing that is a little bit unique to healthcare is the concept of reducing impact of the second victim with psychological safety. In healthcare, sometimes things go wrong, and we know that. Staff that are involved in those incidents often are considered the second victim because of difficulties they have afterwards. Areas with greater psychological safety have fewer problems with second victim phenomenon.
So should you decide to start on a journey to increasing psychological safety in your workplace, there are some challenges that have been identified The first one is unequal power of distribution and status. So what does that mean? One of the most tragic events in the history of aviation occurred when two co-pilots were uncomfortable pointing out something to a pilot, which caused an accident. In our workplace, an example of this would be someone who is cleaning a patient room and notices a provider or a nurse enter without washing their hands, and they are afraid to speak up and ask that team member to wash their hands. Another challenge is negative consequences for honest mistakes. How do you treat your employees when they make a mistake? Do you say, "What were you thinking?" Or do you say, "How do you think we could prevent this from happening again?" Another challenge is unwillingness of leaders to consider the opinions of employees. Do you have an idea box at your work for people to submit ideas? Or do you say, "That's really a dumb idea, don't bring anything forward again"? So those are just some things to think about when you start on your journey to addressing psychological safety. Some personal challenges that your team members may fear. The first one is the fear of being stupid. They might not want to ask a question for people thinking that they are stupid. The fear of being incompetent. Don't ask for feedback because it may look like you're not knowing what you're doing. The fear of being negative, being doubtful or criticizing someone else's idea or work. And then the fear of being disruptive. If they want to bring an idea to do something different forward, they don't want to kind of disrupt the process. So the 4 fears are being stupid, being incompetent, negative, or disruptive.
So we've talked a little bit about what psychological safety is, some challenges to implementing psychological safety or growing psychological safety. And before you can try to implement anything or grow anything in your own organization, the first thing that you should do is try to assess for psychological safety. And what is your organization at as far as in the journey for psychological safety? So Amy Edmondson that Paula referenced, she wrote a book called The Fearless Organization. If you remember from earlier in our presentation, Paula talked about how in the 1990s, Amy Edmondson really formulated the current working theory of psychological safety. I thought it was interesting to know that her landmark paper from 1999 has been cited over 10,000 times on Google Scholar, which is an incredible amount. In her work in the Fearless Organization, Amy Edmondson has 7 questions that you can use to assess for psychological safety within the organization. And we know that some people today may just be listening and may not be able to see the slide, so I am just going to read the questions to you here. So one of the questions is, if you make a mistake on your team, is it held against you? Second question, are you able to bring up problems and tough issues? The third one, do people on the team sometimes reject others for being different? Number 4, is it safe to take a risk? Number 5, is it difficult to ask other team members for help? Number 6, do people on the team deliberately act to undermine your efforts? And the last one is, are your unique skills and talents valued and utilized? And on our slide, we have actually a picture of the book, The Fearless Organization. Paula and I each have a copy. I actually brought mine with me today, and Paula actually has 2 copies because she likes the book so much. I just recommend this book very highly if this is something that you think you want to do in your organization. There are some great stories and examples in that book that talk about manufacturing, healthcare, all sorts of different venues. So there should be some good information in there. As far as how do you actually use those questions in your organization, you could do a couple different things. You could include them if you already do an annual survey of your colleagues. You could include those questions into the annual survey that you do. You could even do something as easy as putting together a Survey Monkey where you would put the questions on a 1 to 5 scale or a 1 to 10 scale and let people rank how they feel about them. If you do a Survey Monkey, though, or your annual survey, I would encourage you to try to figure out how to look at the results both for frontline staff and colleagues and people in a managerial position, because that's also one of the hallmarks with psychological safety is that, you know, management may have one perception of how things are going, but the colleagues at the front line may have a very different perception. So, and here's kind of the meat and potatoes of our presentation today. How do you grow psychological safety in your organization? So leaders have big tasks to try to increase psychological safety in the organization. You want to set the stage, you want to invite participation, and you want to respond productively when people bring things up. So let's talk a little bit more about those. Setting the stage is very important because what it accomplishes is it creates shared expectations and meanings among everybody within the organization. So you're going to frame the work. You're going to set the expectations about failure, uncertainty, interdependence, and clarify that it's okay. It's okay to ask for help. It's okay to say that you made a mistake. You're going to emphasize the purpose for your organization. What's at stake, why it matters, who is it important for, so that everybody knows what those expectations are. And then as far as inviting participation, it's very important that you invite participation because you want to give people confidence that their voice is going to be heard in what's going on within the organization. If they don't feel like you're listening to what they say, you've defeated your purpose of what you're trying to accomplish. So how can you invite participation? Part of that is by demonstrating situational humility. That means admitting that you don't know everything. Our company C, that was part of what we were trying to bring forward with that. As a leader, you can't know everything, and I think it's unrealistic to expect that you would know anything. Admitting that, does that make you weak, or does that make your organization stronger because the people that work with you are able to help fill in those gaps? Practice good inquiry by asking good questions and then model listening. You ask the questions and you listen to what your people have to say. Also, you want to make sure that you've got structures and processes set up. You know, Paula mentioned before, do you have a suggestion box? Do you have a staff meeting where people can bring forward ideas? And what is that venue going to be at your organization? And finally, the last thing that leaders need to do is they need to respond productively. You have to express appreciation, and we've said it before, and we're going to probably say it again before we're done. You have to listen. You have to listen and listen actively to what they're saying. You have to acknowledge and thank them. Thank you for bringing forward that idea, instead of, you know, you're just going to slow us down. We're not going to meet our quota. You know, bring forward your concerns. The other big issue for leaders to do is to help destigmatize failure. You want to look forward. You want to offer help. You know, we already said that before. So let's make sure this doesn't happen again. Give me some ideas on how we can prevent this from happening in the future. Discuss, consider, brainstorm the next steps. All of that moves the organization towards an orientation toward continuous learning. It's okay to make mistakes as long as you learn from the mistakes. The other thing that we do want to point out, though, is you do still need to sanction clear violations. If somebody willingly violates the process, the safety protocol, the whatever, you need to have clear, consistent handling of those violations, because that also helps grow psychological safety. If people are comfortable in knowing how violations will be handled and that it won't be subjective based on how well somebody gets along with the boss, that goes a long way to creating psychological safety.
Just to dovetail what Karen talked about, we recently watched a webinar and they taught us to respond with grace and gratitude. So Karen and I use that a lot lately in our role at Bell, responding to team members with grace and gratitude. This is a graphic that we threw in our PowerPoint just to kind of demonstrate visually and verbally the points that Karen talked about. Making safety a priority, facilitating everyone speaking up, establishing a safe place to to handle failure. Creative ideas are welcomed, and then embracing the conflict in your organization. We talked about organizational challenges and personal challenges for psychological safety. This is displays how your team can support psychological safety. Agree to share their failures, recognizing that mistakes are an opportunity to learn. Asking for help and freely giving help when needed. Embracing expertise among many versus a single person in that team. Encourage and express gratitude, which we talked about, which reinforces the team member's sense of self. And then asking powerful, open-ended questions, and then, as Karen said, listening attentively.
So we wanted to share a little bit with you about Bellin's commitment to psychological safety. At Bellin, we have a team called Civilitas, whose work encompasses how to spread and encourage psychological safety in the organization. They've developed kind of a process where they do a monthly video, and then there are questions to spark conversation, and then those are used by multiple teams throughout the organization. Last count, we were somewhere over 700 members. I'm not sure. I think they were hoping to get to the 1,000 team point, and I'm not quite sure we've gotten there, but we're close. We also are including an element of psychological safety into our new leader orientation. Every new leader that starts with the organization or is promoted within the organization will have some specific education around psychological safety and how they can help impact psychological safety. We also are including this in our annual surveys. Our culture of safety survey that we do has some elements of psychological safety. We did a recent pulse survey which used those questions that we shared earlier. And then going forward, we're going to blend that into ongoing annual employee engagement and culture of safety. So we just started that this year. So again, annually, we will start measuring that so we can monitor our improvements with that. And as far as Paula and I go and just our commitment to psychological safety, every program that we implement as patient safety specialists at Bellin, we're trying to keep psychological safety in mind and really trying to incorporate elements of that into those programs. And then the next slide here, this just shows kind of this is an example of one of the posters that our Civilitas team uses to spread their information. So there's a link to the video and then the questions, and then we have that posted for the different groups to use.
So that's the end of our presentation. We want to thank you for your time today. We do have a list of references located on the PowerPoint for the books and articles that we mentioned this morning.
Thank you, Karen and Paula. We do have one question that came in that I'll ask, and that is, do you feel that psychological safety is easier with different generations?
So I'm trying to remember if there was anything in the articles about differences in generation, and I can't remember that coming up in any of the research that I've done on it in the past or articles in the past. My gut feeling is it would actually be much harder across the generations. You've got I'm a boomer, well, kind of almost a boomer. So if you've got the young person doing the hey boomer, that can be disrespectful. You also have the older generation saying, oh, those young kids, that kind of thing. So how do you develop that respect among the generations? That's a really good question, and that would be something that you might need to work on. But I do think some of what they've said about setting those expectations on how you treat one another, how you expect your colleagues to relate to one another, that you can decrease some of the impacts of that. I don't know what you think, Paula.
No, I agree. I think just using those same concepts and applying them no matter which generations we talk about is important.
Good. And another question, and that is, how do you change the attitudes of people stuck in their routines?
I remember when I first started in patient safety, I asked my leader, how do you change a culture? Because it's kind of overwhelming. And how do you change a whole culture of an organization? And her response to me was one action at a time. So it's not going to happen overnight. You have to mirror what I'll say walk the talk, and then be that good role model for those people that you need to kind of change. And also understanding where they're coming from, meet people where they're at. Maybe they have a concern or a barrier to changing, so kind of learning where they are and then moving forward from there.
Thank you.
Yeah, I think one other thing might be to shake people out of their comfort zone a little bit. I heard a really powerful presentation one time, and it was a physician, and he said, he was talking to other physicians, and he said, what's the worst thing that ever happened to you as a physician? What's the worst, mistake you ever made? Let me tell you about mine. And he started with discussing his issues. So let's say you have a group of people together, you're trying to get them out of their comfort zone, you want to make it easier, you've decided that the one task you're going to focus on for right now is making it okay to admit that something didn't go well. So maybe you get your group together and you say, let's all talk about a time at work that we had a situation not go well, that we made a mistake. Here's mine. And you start it, and you go around the room, and everyone is expected to contribute. Because that way, it's not just a few people. Everyone is expected to share something. So that might be one technique you could try, but I think Paula's really right. You don't change it everything at a time. You pick one thing, you work on that one thing. Then you pick the next thing, and you work on the next thing.
Okay, and one last question, and that is, how can employees start to bring up issues when they're not sure how the coworkers will react?
So, and that's what this is all about, because it's that interpersonal. It's not only from the manager down. The manager's going to set the tone, but it's how the colleagues respond. So I think one option, again, and it kind of goes back to the leader sets the tone. So we're going to talk, every day we're going to talk about this, and you set the expectations of how you want them to respond. Give them some ideas. I'm telling you, here's the book. In the book, there's actually a section in here for, if you're not the leader, what can you do? What kind of questions can you ask? What kind of statements can you make that give that support? So maybe you can start by saying, as the leader, I want, this is how we're going to respond. Let's try using these 4 phrases when people bring things up. It's not going to happen overnight. This takes effort and time. This is not a one and done. This is a slowly over time, over and over again. But again, look in the book. There's a whole section there for you about that.
Well, thank you, Karen and Paula. Very, very interesting. Good information. We'll move on to a short video from Holy Family Memorial in affiliation with Froedtert and the Medical College of Wisconsin now.
Hi, I'm Dr. Milan Kohler. I am the child and adolescent and adult psychiatrist over at Behavioral Health here at Holy Family. I'm here to talk today about depression. Depression is really common. It is the most common of the psychiatric illnesses, along with anxiety. Some of the more recent statistics from the CDC as of June 2020 shows that 31% of the respondents had increased symptoms of depression and anxiety over the course of this year. 26% had trauma-related symptoms. 13% had started or increased substance abuse to deal with their depression and anxiety symptoms, and 11% of people had seriously contemplated suicide. And that rate is even higher when you take younger adults separately from the rest of the population. Well, because it's so common, there's a lot of things that can actually cause and lead to worsening of depression symptoms. There are going to be people who have a predisposition because it runs in their family, because there are hormonal changes. There's twice as much risk for being a woman just because of hormone changes, and that will go up again with menopause. There's going to be situational changes that can lead to a worsening of depression symptoms. And there's a lot of situational changes this year especially. So there's a lot of things that will lead to a worsening of those symptoms. With depression, it would look like sadness most often. You need to be sad for at least 2 weeks for a clinical diagnosis of a major depressive episode. But oftentimes you don't even notice it as sadness. Sometimes it's blah. You just have a numbness of feeling. And during those 2 weeks, there's disruptions in sleep. People will sleep a lot more, or they might sleep a lot less. There's going to be less interest in things. The fun stuff just isn't fun anymore. They don't want to do it. There's decreased interest, motivation. There isn't energy during the day. The appetite changes. People will start either stress eating, stress not eating. Either way can be seen. There's sometimes guilt, unreasonable guilt. It's not the kind of thing where you did something wrong and that's the kind of thing you're guilty for. No, this is going to be something that's completely out of proportion and not naturally something that you would feel guilty for. Sometimes, this year especially, you might feel guilty for not being sick or not being sick enough if somebody else was having a really tough time this year. There's helplessness, hopelessness, worthlessness, sometimes thoughts of suicide or even hallucinations. In order to diagnose it as a major depressive episode, you only need 5 symptoms on top of the depressed mood. So you can see how common it is. And what it would look like would be, besides the sadness and not wanting to do things, a lot of people isolate. They'll stay in their room. They don't talk to people. They withdraw. They don't reach out when they normally would. They're just kind of sunken in and just not quite themselves. Some people will describe it as if there's a distance between what they usually feel and what they normally want to feel. All of that is worse this time of year especially because we're socially distanced. We don't have the same opportunities to spend time with our friends. We don't have the same outings. We don't have the things that we want to do. With the time change, with winter, with it getting darker that much sooner, a lot of our circadian rhythms are off in addition. So all of that will add to the really low, draggy kind of feeling that can happen at this time of year. So any of these symptoms, you want to be really careful about with yourself and with people that you know, because it is common and it can very quickly get even more intense. There are easy things that you can do to try to counteract some of these symptoms without necessarily having to meet a professional like me. The things that you can do on your own would be to try as best as you can to stay active. I know physically active is really difficult right now, but you want to at least be mentally active. You want to have some sort of activity in the house. That means either physical activity, exercise. I know, evil. We don't like it, but you need it. You need to have some sort of physical activity to really give you that energy during the day, especially in the afternoons when it starts getting dark. You really want to have more energy to deal with that. You want to have brighter lights in the house and around you. They have medical grade light boxes for relatively cheap on Amazon, believe it or not. You want to look for something that is rated at least 10,000 lux as a rating. Just as a for example, average room light is 300 lux. So this is really, really bright. Follow directions on the box. You don't look at it. It's meant to trick your brain into thinking it's the sun. So you'd have that in the morning, usually with the 10,000 rating box, about 10-15 minutes in the morning, off to the side a little bit, you don't look at it. It's there for your eyes to pick up the light and to reset your circadian rhythm. You can do it with bright lights at home, not necessarily just the medical grade box, but obviously you may have to have more of them in your house, since most of them, living rooms don't really have overhead lights and most of us don't have really super bright lights. You definitely want to have more of that around right now. Vitamin D is not something that those of us in Wisconsin have a lot of. So you may want to have it formally checked and replenish in order to make sure that you don't feel draggy and run down from that. Other vitamin deficiencies you'd want to look into that are common would be like B complex vitamins, iron, magnesium, things like that, because those can also lead to a lot of mental slowdown and fatigue throughout the day, as well as other medical issues like anemia. Sometimes thyroid hormones you'd want to check out too. So when you do notice that the depression is bad, sometimes people have thoughts of suicide. That is something that we want to take very seriously. And it freaks people out. They don't want to talk about it. People sometimes don't want to ask about it because they're scared of what people will say. Try your best, if you have concern about that with someone, to talk about it in a neutral kind of way. You're not going to judge somebody for having these thoughts because it's a sign of being overwhelmed. It's not a weakness. It's not something that says that you're bad, that you did something wrong. These thoughts happen, and there's a lot of people who walk around with thoughts of suicide they never act on. That's the default that their brains go to when they're really stressed out. So you want to ask, what brings on these thoughts? What kind of thoughts are they? Are you really going to act on them? What can we do to help make those thoughts go away? Because usually when the thoughts come, they're not going to stick around for a long time. Usually they're temporary. They're brought on by stress. It's a stress reaction. It's a serious stress reaction. We don't want to take it and pretend it's not there. But we don't want to freak out and then possibly make the person withdraw even more and not want to tell you about it. So you really want to identify who has these thoughts. So someone who's really depressed, someone who's really not reaching out, you want to reach out to them. See how they're doing. Make sure that they're okay, that they are getting some kind of activity, that they're getting themselves checked out to make sure there aren't physical things going on, that they have somebody to rely on as much as they can, that they have something that can be a distractor in those times. Usually we talk about things like the exercise as a distractor. You want to have whatever it is that normally makes them happy. So music, books, movies, things like that. I've had one patient say that what they really enjoy doing was popping bubble wrap. So it really doesn't matter what makes you happy as long as it is something that for that moment can really push past that thought of suicide and get you on the other side of it. When it doesn't go away, if it's not something that can be easily pushed aside when that moment goes past, that's when you really want to start looking into what additional help can you get. Can you start going into a therapist's office? Can you talk to a psychiatrist? Can you talk to your primary care doctor if you can't get in right away? There are crisis lines. There's the national hotline now. There's text messaging for those who don't like talking online. There are always ways to deal with this that don't always have to be scary. If that's not enough, then the next step would be trying to call 911 or going to an emergency room. You always want to be erring on the side of caution to be safe. That's the biggest point. You want to let people know that they're not alone and that you are there to help them be safe. So if that's something that you really feel worried about, if the person that you're worried about or yourself, you don't feel comfortable talking to somebody in person, find somebody who can do that for you, because that's okay. It happens more often than you think and more often than you're afraid of. And at this point especially, we really want you to be safe and everyone around you to be safe.
Welcome back. I'd like to introduce Kristen Jakes with Bellin Health, who has sponsored today's event. Thank you so much. Kristen?
Well, good morning, everyone. My name is Kristen Jakes, and I'm happy to be here, but I'm even happier that you've joined us today. So thank you for that. We just wanted to extend a little bit on the psychological safety portion of our symposium today. The reason we want to do that is because we really feel it is so important as the times are changing. The question about the generations was extremely interesting. Not to mention, how do you change a culture? And that's really the question. Not only do you have all of those elements, but you also have COVID in there, and you've got other things that are impacting. From a manufacturing perspective, you've got supplies that are on back order. So there's so many things affecting the quality of the productivity. And one of the things that really helps is psychological safety. So just to extend a little bit of the Bellin commitment to our individuals here listening today, Bellin is donating 10 of those books. So if you went on Amazon, you may still have time to cancel the order of the book if you put it through, because we did draw names for 10 individuals who did register. I have them. I'm going to read them, and I'm going to apologize ahead of time to say that I may be making a mistake in the pronunciation of your name, but let's try it. So the following individuals are the 10 lucky winners of the Fearless organization. Great read. Trust me, it will not put you to sleep at night. So it's not like one of those novels you'll read because you want to get some sleep. You're going to get jazzed up by reading this. So you lucky winners, are you ready? We've got Tracy Gadke, Carrie Miller, but it's Mueller. So we've struggled with, is it Miller or Mueller? So Carrie, you're a winner. Sam Pamprin, also a winner. Holly Sheets, Scheidt. Again, apologize, I'm not a good pronouncer. Amanda Ansorg, Haley Lindholm, Crystal Cass, Kim Model, Moddle, Lisa Yonk, and if you're sitting on the edge of your seats, you're going to be number 10. Guess who you are? Raise your hand if you are Mike Koss, because you are the winner. So, Tracy, Carrie, Sam, Holly, Amanda, Haley, Crystal, Kim, Lisa, and Mike, you are the winner of the Fearless organization. Now, how are you going to get your books? We have your email addresses. The Chamber is going to reach back out to ourselves here at Bellin. I'm going to reach out to you. My name is Kristen Jakes. It's KRISTIN.JACQUES@bellin.org. It is not a spam, so if you see that come through, we're simply going to be looking for your address. We will mail the books to you, so you will be able to get into the Fearless organization, get into the book, and really help out your organization in starting to implement some of those psychological safety elements. However, to give you just a little bit more insight about the contents of the book and a little more thinking, I'm going to bring Karen back. We're going to walk through a little bit of the book and just talk about how you can implement this into your organization. So with that, I'm going to turn it over to Karen.
Oh, I thought you were going to join me. Hi, everyone. Thanks for giving me just a few more minutes. Psychological safety is one of those things that when I first heard about it, the first article that I read about psychological safety was actually about the 4 fears, and it's cited in our reference slide that was there. When I heard that, I was a frontline staff member, and I thought, oh, this is it. This explains everything. And I could think back on the times in my own life when I had been afraid to speak up, or when I had brought something up and was not made to feel welcome for that, and so then hesitated bringing anything up again. And so I think all of us can learn from the concept of psychological safety. And I remember too, just the impression that that this is stuff we all know. As soon as I heard it, I thought, yes, this is for sure what those feelings have been about. And so it just put a name to it, and it summarized that in such a fashion that I thought was just so brilliant. And then I got more into the work of Amy Edmondson, who again is the author of the book. I feel like I'm doing a commercial for her, and that's really not what this was intended to be about. But when you find something that you think is so good and so powerful, you tend to go back to that. So I again just encourage you to read the book, but Amy Edmondson's work, her initial work was done in healthcare, which I think is why it resonates so strongly with Paula and I, because it makes so much sense from a healthcare perspective. And you guys all know that from the safety work you can do. You know, you can have zero colleague injuries, and you can have zero injuries because nobody reports them. And if they're not reporting them, it doesn't mean they're not happening. It just means you're not aware of what's going on. And the same thing happens in healthcare organizations. We are no different than any other place. Things happen, but if you don't talk about them, learn from them, and change the culture so that instead of it being punitive, you're punished for making a mistake. And there are some very tragic stories in patient safety regarding people that were failed by the system around them and then were abandoned by those organizations, not psychologically safe at all. And so learning how to grow that in an organization, whether it's healthcare or manufacturing, makes a lot of sense. So again, the Fearless Organization, she's got some great stories in here. One of the ones that I really like is about the Volkswagen company. If you remember the whole Dieselgate story, they had put so much pressure on the staff, and this came right from the leadership. You know, the head of Volkswagen said, we will make this car, it will happen. There will be no excuses. I will allow no opportunity for this not to happen. Would publicly belittle people if they didn't accomplish what he wanted to. And so no one could speak up and say that there were problems with this theory or what he was trying to accomplish. And we all know what happened with Volkswagen. It nearly put an end to the company and the amount of problems that they had. So one of the other things that somebody asked about and we wanted to talk about, somebody talked about the different generations. One of the questions we had was about the different generations. And how do you encourage that conversation among colleagues, and how do colleagues relate to one another? So there's a part in this book that really stuck out to me. It's one of my dog-eared pages in the book. And there are phrases that you can use with staff in general. If you're not the boss, how do you affect psychological safety? And Edmondson has in her book a few ideas, and they're so simple, they're almost brilliant. One of the things is to say, I don't know. I don't know the answer to that question. I feel like I say that a lot. I tell people all the time, I don't have any answers, but I have a lot of questions. And I don't know that that's necessarily a bad thing, because I'm not necessarily the one that should be figuring out the answer to the problems. It should be, it should be the people that are at the front line and that do the work. So I don't know. I need help. Make it okay to say, I need help within your organization to help grow psychological safety. To be able to say, I made a mistake, this is what happened, this is how we are going to fix this going forward. And then a next thing is to say, I'm sorry. If something happened to somebody or you made a mistake, to say, I'm sorry. So I don't know, I need help, I made a mistake, and I'm sorry. Other powerful questions that you can ask and that you can encourage your colleagues to ask of each other is, what can I do to help? What are you up against? If a leader came to me and said, what are you up against to accomplish this project, to finish this project, that would mean the world that they were trying to understand my level and what I was trying to do. And then finally, the last one, what are your concerns? If we implement this new product, process, technology, what are your concerns with that? And then actively listening to that. And again, you can do that with your colleagues. What are your concerns running this machine by yourself? What are your concerns coming off orientation? All of those will help create psychological safety. So, Kristen, was there more that we wanted to talk about with this?
We can go to a break.
Excellent. Thank you very much for allowing me to speak a little bit more about psychological safety and the Fearless Organization.
Yes, thank you very much. We're going to pause for 5 minutes before our last presenter begins. Thank you all. Welcome back. Our last speaker for the day is Tom Fitzgerald from Safety Fits. Tom is a safety and health consultant and OSHA outreach instructor who founded Safety Fits, LLC. Tom is a former HR manager with Parker Hannafin in Manitowoc with over 40 years of manufacturing, human resources, and safety and health experience. Tom?
Okay. Good morning, everyone. My name is Tom Fitzgerald again, and I'm here to give you an OSHA update a little bit about their activities. And this is kind of an update from the presentation I did a year ago. So some of the slides, I did use some of the slides from last year, but I did update them a little bit. And there's also a lot of information here that we're going to go through some of it very quick. I'm going to speak to the high points a little bit. And this is my understanding this will be available to you if you want to go back and look at the details. At a later date, they'll be available through the chamber. So, without any more, I'll get started. So the first thing that's changed is, of course, COVID's in the news. It's the number one thing that we always talk about. You see, this is a little graph I got from the New York Times that talks about the rise and increases of cases since last year and over the course of the pandemic. You can see that we've had a little spike here in August and in September. And that's all in the news, and we hear very much of it. Down below it says so far in Wisconsin we've had 771,000 confirmed cases, and regrettably, we've had 8,700 deaths. In Manitowoc County, we've had 10,000 confirmed cases and 99 deaths. Oops. Some of the things that I think were important, a lot of stuff happened in the last year, but some of the things that pertinent to my discussion is number one, in December 14th, we had our first Pfizer shot vaccination. In January 9th, the pandemic basically did hit its peak at 253,000 cases for a 7-day average, and we had 251,000 new cases. We're approaching that level now, and it's creating a lot of concern. Of course, on January 20th, we had a new administration takeover with a new focus. President Biden's definitely more labor-oriented than President Trump, so he immediately made some changes to OSHA. You can see down below I have a graph of those vaccinations, and you can see we've had a steady rise, and now here of late we're starting to flatten out a little bit. Currently in the United States, for fully vaccinated, we're at 55.2%, with one dose being at 63.3%. Also on June 21st, 2021, OSHA issued its latest, what we call ETS, Emergency Temporary Standard, on OSHA, and COVID, and that was focused on mostly healthcare. And you can see they issued 4 separate standards, one on healthcare, 1910-502 through 505, and those particularly address healthcare. And then they also issued on June 28th and July 7th 2 CPLs, which are what we call in the business compliance documents. These are basically directed towards CES, compliance, safety, and health officers of OSHA, and kind of basically tells you how they go through their audits when they come visit you. I would certainly urge you to go on the OSHA website and get those 2 documents if you are especially in healthcare. It may also be a good idea if you're not in healthcare, just to give you some idea that what might be down the road coming up for us, for the rest of us. I'm going to go through the next slides pretty quick because they basically have to do with the ETSs currently in effect on healthcare. The one that I really thought was pertinent was this one. I just thought it was interesting that it said here that for some areas, as I understand it and as I read this, if you are vaccinated, you're exempt from certain provisions of the overall ETS. If you want more information, I have some slides down here at the bottom. There's also a very informational quick start guide that I found from the Healthcare Alliance that you might want to download, and I put the links there for that. The OSHA website, OSHA.gov, has a lot of pertinent documents. These again are pertinent to the current ETSs on healthcare, and they walk you through certain things. And I think you'd find them very helpful, especially again if you're in healthcare, if you wanted to use those. And this is their page on the OSHA.gov website that talks about specific provisions of the ETS, and how they're administering it. Also gives a lot of information about those of us that aren't in healthcare that might help us with our pandemic plan and protecting our employees from COVID. Also on August 9th, all federal employees in the executive branch, including the U.S. Armed Services, President Biden put an executive order out saying that they will be vaccinated by November 22nd. On August 10th, President Biden notified all federal contractors that they need to have their employees vaccinated. On December 9th, he did issue instructions to OSHA, which he announced in a press briefing, saying that all employers that have greater than 100 employees will also have to have their employees vaccinated as well. And he's issued instructions to OSHA to issue an ETS, instructing those employers to have their employees vaccinated. And that's, of course, ignited a lot of fear and a lot of controversy. As of September 10th or 19th, OSHA is still working on the ETS on vaccinations, and everybody's anxiously awaiting that. Below, I have a clipping from the press briefing on that. But again, OSHA will be issuing an ETS on vaccinations and make this all a lot clearer, hopefully. OSHA, the rumor is out in the business world that OSHA was caught kind of flat-footed. They totally didn't expect Biden to issue instructions for them to issue an ETO on vaccinations, so they're working feverishly to try to catch up. But again, that's just a rumor, and they have not confirmed that. First, the heart of the OSHA Act, I want to remind everybody, is the OSHA General Duty Clause, Section 5A. And it basically says, and I want to remind everybody of this, each employer shall furnish to each of his employees employment and a place of employment which are free from recognized hazards. Now, I underlined free from recognized hazards because therein lies the controversy. Is COVID a recognized hazard? I can tell you this, for years and years, OSHA has recognized other communicable diseases, such as tuberculosis, as being a recognized hazard. So there is some precedent for bringing COVID into it. However, Section 1904 explicitly exempts colds and influenza from the OSHA record-keeping standard. So basically, the legal precedence, in my opinion, basically first rests with whether the General Duty Clause is valid. Excuse me. The next legal issue that's going to be issued is OSHA is going to use the fact that they feel that COVID restricts interstate commerce, and that's why the need for vaccinations. Third, the statute that creates their ability to create ETSs says that they have the ability to create an emergency temporary standard based on grave danger. And that's going to probably be the biggest legal test is COVID a grave danger or not. Of course, in the movie We Were Soldiers, the colonel says any danger is grave danger. So, fourth, several Republican state attorney generals are threatening legal action, basing all kinds of things. Basically, the ETS, the upcoming ETS, is going to be unconstitutional. From what I understand from several legal scholars going to number 5, that it's kind of a mixed bag, but from what I've read and what I looked at, the information on the internet, looks like a small majority of legal scholars feel that President Biden does have the legal right to provide the employers that have more than 100 employees require vaccinations. Sixth, the question is not, in my opinion, it's not the legality of whether President Biden can do the ETS. In my opinion, he probably can. But my concern, or not my concern, but I think the greater point is OSHA's stretched the limit right now. I'm not sure how they're going to be able to enforce it, how they're going to enforce this mandate for several thousand, many thousand employers. So we'll have to see how that plays out. And that's what I said in this slide, that they just don't have the manpower. And I'm not sure how fast it's going to take effect. I do think that they won't be going out auditing to see if you are vaccinating. I think where they'll have to concentrate their efforts on if they get any employee complaints, any of your employees call in through the what they call the Rapid Response Investigation Program. They'll ask you questions about whether you're having your employees vaccinated, and if you are not, then they'll probably try to attempt to issue citations. But they're not going to come out and start auditing en masse. They just don't have the manpower right now to do that. I think this leads to my critical point to my customers that I make, that this makes our job of preventing COVID in our workplace even stronger. We have to do everything we can. We should have a full COVID response plan or pandemic plan, and instituting that to try to prevent, because I think that, again, the main the main emphasis on OSHA's enforcement of this ETS on vaccinations will be the employee complaints. And if you don't get any employee complaints, you won't be in the radar. So again, I think that leads credence to emphasizing your COVID pandemic response plans and those corrective actions. Okay, so if you're less than 100 employees, you might be thinking, well, I don't have to worry about this new ETS. I'm exempt. That's true. You won't have to worry about this ETS. However, I don't think you can jump to that conclusion this quickly, because even if you have less than 100 employees, the OSHA General Duty Clause does affect you, and OSHA could say that, ask you, are you protecting your employees from recognized hazards, including vaccinations? So I still think you need to be prepared and be thinking about what you might do if that starts becoming reality. So you are not free and clear of making your employees have vaccinations, in my opinion. Then who will pay for this? Right now it looks like the employer will. There is some legal precedent for that. However, I do think the current information that I was able to dig up shows that the feds will probably be giving some help, at least to smaller employers and those that need the help to get the vaccination. So there may be some federal assistance with the pay. But again, we'll have to see how that comes through. Just some general statements, and these again from last year. These talk about your basic requirements for recording. And yes, COVID, if it's deemed to be cause from the workplace, would be a OSHA recordable. You basically have to take the evidence or the word of a medical practitioner. If a medical practitioner says it's work-related, it probably is, until you can get an IME or something that proves otherwise. From my last year's presentation, these points are all still critical. You still need to be on top of things, watching how making sure, keeping a good pulse on your employees and how their health is going. I would urge you to do all these things. Again, I'm not going to take time to read them all today, but this is, in my opinion, the critical components of a pandemic response plan. But the paradigm shift has occurred, and I believe that COVID's here to stay for a while. Again, this is an employee pandemic questionnaire that you might want to ask all your employees. If an employee comes into HR and says they have COVID, or they call in and say, you might want to fill out this form on them, just to kind of keep track of it. And this helps you kind of make a decision on whether you're going to take it as work-related or not. Here's a citation that OSHA actually cited a warehouse down in Naperville, Illinois, for not responding to COVID in the workplace. Again, this doesn't specifically talk about vaccinations, but it does talk about the employee not taking corrective actions when they suspected COVID in the workplace. And I think the company got fined several $1,000s. I think it was a major violation. So beware. They can use the general duty clause to enforce and remind you that you have to protect your employees from recognized hazards. OSHA encourages, I also remind you to know this, you should all have this poster up. OSHA reminds all your employees that if they have any health concerns or safety concerns, they can call them and should call them, so that your employees have the ability to call OSHA. Again, just a reminder that you do have to call OSHA on any health or safety illnesses where somebody's hospitalized, they have an amputation, loss of an eye, or there's more than 2 people hurt for the same incident. You must also inform OSHA of all workplace fatalities within 8 hours. Hospitalizations is 24 hours. What else is OSHA up to? Well, OSHA's really trying to catch up from really dealing with COVID last year. They were just trying to do that this midsummer to late summer, but now they're finding themselves embroiled in the COVID controversy again. However, they were trying to change and review the HAZCOM procedure, OSHA 191200, which they're trying to get industrial comments on and public comment. But they would like to, for instance, update all the permissible exposure limits. Those are all pretty much, they're 50 years old almost. So they're trying to get information about that and update the whole HAZCOM procedure. They wanted to increase their targeted inspections. However, with COVID and some of their rapid response investigations, they have not had the manpower to do that. All hands on deck right now, or OSHA are struggling to keep up with COVID and the rapid response investigations they're doing. So they've had the target inspections are sort of on hold. They don't want that to be that public knowledge, but they're not happening very often. There's also, for those of us that do a lot of machining, there is a national emphasis program on amputations. And there are also local emphasis programs you should pay attention to. Here's the national emphasis programs, and they specifically target businesses with these health concerns. I'm not going to read them all again. But again, number 3 is amputations. That's a big one for most of my customers that are in manufacturing. And be cognizant, that's going to come up a little bit later in my slide, that if you have an amputation and you're on one of the targeted NCIS codes, you will have an OSHA inspection, almost certainly. Okay, these are the local emphasis programs for our region, Region 5, the states of Minnesota, Wisconsin, Michigan, Indiana, Illinois, and Ohio. And these are pertinent to, you should review this to see if any of these, if you're doing any of these activities. Again, there's a national emphasis program, and going back to the amputations, I talked about this is it. There's a CPL also for compliance and health officers when they come in and are investigating an incident where there's been an amputation. I tell all my customers it's a good idea to have this CPL, because basically this tells you exactly what OSHA is going to look for when they're investigating an amputation. If these are the NCIS codes that are involved, if you're on this list, again, reminding you what I said a few minutes ago, if you're on this list and you have an amputation, you're almost certainly going to have an OSHA visit. Conclusion, I still urge all my customers and all the rest of you to always act in good faith with your employees' health and safety in mind. As long as you present that, OSHA will be more compliant in my experience. Certainly want to do ongoing risk assessments and implement controls accordingly to protect your employees. Investigate all reported on-the-job injuries and illnesses, especially those that are COVID related. Document root cause controls. And whenever you're dealing with OSHA, document. You should try to be as transparent as possible with your employees. Along those lines, I don't have it here, but I also urge you not to surprise people. Make sure that they know what you're doing and why you're doing it. And at the base, the reason you're doing it is you want to protect them from health and injury. Train. Anything you do change or act upon, make sure you're training your people. Ask if you need help. Ask medical providers, ask your insurance company, corporate, whoever you have as a resource. Get all the information you can. Network, that's why we're here, all of us today, to network and get to know each other and help each other and call each other. Above all, talk and act like your employees' health and safety is essential. I like to tell my customers it's an internal essential value. It is something that we just do here. And if I can help you in any way as safety fits, I'd be glad to do that. Here's some references. These are all really, really good ones. The one I really want to talk about that's new is on the bottom. This gentleman's on LinkedIn. He's a lawyer for Ogletree and Deakins, which is a big labor relations law firm, national law firm, and they also have a specific OSHA compliance team, and Phil's one of the top guys. And he almost every day he posts information about OSHA and its activities and how to handle rapid response investigations, how to deal with OSHA during an audit, all kinds of information. So if you're not hooked up or linked or connected with Phil, I would certainly urge you to do that. A lot of information. I also would tell you to hook up with OSHA.gov. Right when you log in on OSHA.gov, you'll get a question if you want to get the OSHA quick takes. I certainly would sign up for that if you haven't already, because then they'll send you an email at least a couple times a month, even more often, and they'll give you updates of their activities and what they're up to. So I would urge you to do that. Again, the local Appleton office is listed here as well. And certainly use the CDC and NIOSH as well, and the Manitowoc and Sheboygan County Health Departments. And that's my whole presentation. Again, it's a lot longer than that if you want to spend the time to go through it, and it's going to be available at the Chamber website. Are there any questions?
Thank you, Tom. Actually, just a few questions. One, you've used the term ETS. What does that stand for?
Stands for Emergency Temporary Standard. In the law, they have the same OSHA then has the same enforcement if they do any other standard. 1910-212 for machine guarding, 1912-100 for HAZCOM. So when OSHA issues an ETS, it's Emergency Temporary Standard. Usually when they form a brand new standard, they have to go through public comment. Might take years for them to come up with a standard. But when they have an emergency for grave danger, they'll issue these ETSs. Now, most of them are upheld within court. The only one that I can remember where it hasn't been upheld in court is back in 1983. They had an emergency temporary standard issued on asbestos and asbestos removal, and a federal court did pull that back down or nullify that. But that's the only one that I can think of where they've nullified an ETS, emergency temporary standard.
Thank you, Tom. Another question, and that is, what is the expectation of employers who have employees who do not wish to be vaccinated from COVID?
Wow.
And how do employers monitor those people without violating HIPAA? And according to the federal mandate, must the employers then perform COVID testing on those employees who are not vaccinated?
You ask a billion-dollar question with that one. And that's going to be coming out in the ETS, so I don't really have the whole answer. What I think, this is my take on it from being a student of the whole thing. First of all, I think if you're a federal contractor, you're going to have to vaccinate your employees. For those of us that have dealt with the Office of Federal Contract Compliance, OSHA and EEOC are pussycats compared to those guys. And I just think that they've really got you there, and you're going to have your employees vaccinated. Now, there probably will be some, again, the speculation is there's a very good chance that there may be an out for religious convictions and or medical reasons. But how they're going to do that, I don't know. You've read a lot of comments on the internet about chiropractors selling slips saying people can't have a vaccination and all this stuff. So who knows? But that's probably what's going to come down to. They're going to give exemptions for medical and religious things. But first of all, if you're a federal contractor, if you're not talking about having to do this, you probably should, because I think that's probably a done deal. That is a done deal, basically. If for the rest of us that aren't federal contractors, then we have to wait for the ETS and see what OSHA really does with all that. But that's a very interesting question, and we're all anxiously awaiting to see how that plays out.
Thank you, Tom. Very, very interesting, excellent information. To close, we'd like to thank you and everyone who has attended today. We'd also like to thank our speakers again for all the great information that you've shared. And again, a big thank you to Bellin Health, who sponsored today's event. If you've enjoyed this presentation, please continue to look out for Manitowoc County Safety, Health, and Wellness Council webinars and future events. We've had a lot of great information coming up soon. Thanks again for everyone joining us, and we hope to see you next time.